If you are looking into starting your own cardiac CT practice, SCCT has developed a tool to help you efficiently achieve your goal. The SCCT Starter Kit is a broad set of resources compiled by clinicians working in partnership with industry professionals. The kit is a one-stop collection of information that includes financial and operational planning templates, resources for clinical procedures, guides for personnel training and credentialing, device and equipment information, marketing tools, and more. Resources are available by link or for download. Subscribers have access to a Q&A and discussion forum. Check it out at scctstarterkit.org. Okay, so Alastair, what famous person, past or present, do you think would be the best cardiac CT reader?
Praveen, this is another one of your meaningless exercises, isn't it?
Come on. Just humor me with this one. Go for it.
Okay, well, I'm not sure, but maybe Henry VIII.
What? Henry VIII? Why?
You like this. Well, because no one could accuse him of ever being wrong. And if they did, he issued swift and definitive judgments.
Wow, brutal. But yeah, I guess I see your point. For me, I'm going to go with Serena Williams.
Let me guess this one. Is it because she's able to serve up the best reports?
No. Not quite.
Well, let me have another go. Maybe it's because no one can match her CT prowess.
That's a pretty good reason, actually, but not quite what I was thinking.
Maybe it's because she never makes a fault with her reads.
Okay, Alastair, look, am I really that predictable when it comes to using corny puns for my justifications here? Come on.
Well, I just thought that maybe.
Let me tell you the real reason. It's because she'd be able to crush a list of studies without making a racket. You get it? Without making a racket.
Okay. But Praveen, let's move on.
All right, Alastair, let's get back to our regularly scheduled programming then, shall we?
Right, Praveen. Well, listeners, welcome back to another episode of The Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Alastair Moss, and I'm a cardiologist in Leicester in the UK.
And my name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. On today's episode, we have another installment in our series, Building a Cardiac CT Program.
To bring insight on building a cardiac CT program in the UK, on this episode of the podcast, we are joined by my friend and colleague, Dr. James Shambrook. Dr. Shambrook is a consultant cardiothoracic radiologist at the University Hospital of Southampton in the United Kingdom. He is the president of the British Society of Cardiovascular Imaging and the British Society of Cardiovascular Computed Tomography, the national specialist interest group for cardiac imaging CT, and works to promote the highest standards of practice of cardiovascular imaging across the United Kingdom. James, welcome onto the podcast.
Thank you very much for having me. It's a privilege to be invited. Thank you.
James, this is going to be excellent. Thank you again for coming on board. We are looking forward to hearing from your perspective with regards to the unique considerations of starting and growing a CT practice where you are in the UK. However, let's first learn a bit more about you. Can you talk to us about your journey through the field of cardiac CT thus far?
Yeah, sure. So I've started radiology training back in 2004, and I trained in Southampton. And interestingly, the reason I wanted to come into radiology was a passion for cardiothoracic imaging, because I'm a cardiothoracic radiology, heart and lungs. And that was an interesting time because we were probably, as I started my training, largely using 4-slice CT, moving up to 16-slice CT. And as I went through my training program, it was clear that cardiac CT was beginning to emerge, albeit it was really challenging on that sort of equipment. And I, as part of my core training, but then later on towards the end of my specialist training and fellowship training, where we started to move towards 64-slice CT, we realized that this was a technology that was really going to take off. We had to work very hard, but I spent some time in my final year as a trainee and as a fellow visiting other hospitals to learn how they were using newer equipment, to develop those skills, to bring it back. And then I started my consultancy in Southampton in 2009, where I continued to practice cardiac CT there. And as you'll be aware, the technology has just exploded since 2009. 2009, and it's been a real learning curve from fighting long and hard with beta blockers and heart rate control and dealing with difficult conditions like atrial fibrillation initially to now, fortunately, having equipment that really helps us deal with some of those challenges. And we've seen a massive expansion in the volume of work we've been doing over that time.
Fantastic. And with regards to where you're specifically practicing, the audience for our podcast is international. So, bearing that in mind, can you describe a bit more about the healthcare system in which you are doing cardiothoracic imaging, perhaps with regards to size, location, types of patients, etc.?
Yeah, certainly. So I work in the United Kingdom, so I'm working within the National Health Service, and the institution where I practice is a university hospital. It's the University Hospital of Southampton. So we're a fairly large tertiary hospital based on the south coast of England, placed pretty much in the middle between, about 2 hours away from London, in the middle of the south coast. And our local population is of the order of 1 million, but our tertiary population is up around 3 to 4 million. As far as our practice with cardiac CT, that's varied. By and large, the larger scale is just standard CT coronary angiography. And for those of you who don't know, the United Kingdom was one of the first countries to bring cardiac CT into its guidelines. As early as 2011, they were proposing calcium scoring for the investigation of chest pain. And then in 2016, they brought in CT coronary angiography as the formal first-line investigation. So we have a large volume of patients that would be appropriate for the scanner. And one of the challenges we've had in the United Kingdom is actually coping with what was quite an acute change. It really was a flick of a switch when Nice Guy, the National Institute of Clinical and Health Excellence, said this is the test for the investigation of chest pain. And now they handed that back to the hospitals and said, right, deal with it. And so that's been a real challenge, exploding the number of patients that we need to investigate. But we're getting there, although it is a bit of a challenge. I think it's perhaps easier in some of the larger hospitals for the simple reason that you have more members of staff and potentially more equipment, and therefore you have more capacity for dealing with this. And so in Southampton, we were one of the early adopters, not the first. There are other centres in the UK that were certainly pioneers. The Royal Brompton Hospital and Derriford Hospital in Plymouth were doing a lot more CT before us, but we were certainly one of the early adopters of using this technology in the UK.
So you had mentioned that the NICE guidelines, or really the update to the NICE guidelines, was a main pivotal point for cardiac CT in the UK. But I presume that the cardiac CT program had started well before that. So wanted to get an idea as to who the stakeholders are when you're considering setting up the cardiac CT program in the UK, particularly in the pre-updated NICE era. And now, what does your routine cardiac CT program look like on a day-to-day basis?
Sure. Yes, you're right. We had started before that time. And as I said, in 2009, I was visiting other hospitals to learn about their practice. I think the key stakeholders for us, and probably elsewhere in the UK at that time, it was those people who were most interested in it. I think those people who had an insight to what the technology was likely to be able to do and bringing it into their practice. So it was passionate individuals who understood that there was value to patients in this technology. And in our institution, that was the radiology department. We have a dedicated cardiothoracic radiology department where at the time there were 4 members of staff. We've subsequently expanded quite significantly from that. But I think these were people who were experienced in cardiac MRI, some experienced in catheter angiography as well. And they were doing a lot of CT for thoracic work and aortic work. But then as ECG gating came along, it became clear that imaging the coronary arteries in this non-invasive way was a useful thing to do. And so I would say there was, my colleagues at the moment, Charles Peebles and Stephen Harden, who appointed me, they were the guys who initially said, this is a technology we need. And as soon as we had equipment in our hospital that was capable of ECG gating, they were keen to start experimenting with it and seeing how they would get it to work best for their patients. And that is how it worked. And as soon as we started doing some cases, we have multidisciplinary meetings like every other hospital, and we would start showing those cases to our cardiologists, both the adult cardiologist and the congenital cardiologist, saying this is what we're capable of doing. And it was a slow evolution, really, of actually every now and again there would be a case that would come along, and we would do a case, and it was of clear clinical value, and that would generate interest. And off the back of that, we started to see more referrals from our cardiologists coming forwards. Moving on to where we are now, The reality is, I think we now have cardiac CT lists running at least one list every day, and we're probably doing of the order of about 60 or 70 cardiac CTs a week. The majority of that is patients from the Rapid Access Chest Pain Clinic who've presented with chest pain and being investigated for coronary artery disease. But because we're a tertiary surgical centre, for congenital heart disease, both pediatrics and adult congenital heart disease, we are seeing a significant expansion in the amount of requests we're getting for investigation of congenital heart disease. I think that has happened predominantly over the last 4 or 5 years with the latest equipment that we've got now. We've now got one of the latest generation scanners which can scan very quickly at low doses. And previously, those patients who would have had to go to the cath lab for investigation of their congenital heart disease, that we're now doing CT scans. And we're beginning to learn the real benefits of that. We've got a practice where we're now using routine 3D modeling for some patients as well. So the volumes have increased quickly, and we are doing quite a diverse practice with regards to ischemic heart disease, congenital heart disease, and we also have a structural program where we're doing a reasonable amount of work for TAVR.
Wonderful. I imagine for some of the complex congenital cases, the types of scanning require a little bit more monitoring, either in person or directly available. Can you give us an idea as to how much time is typically split between supervising scanning or overlooking protocols for scans relative to reporting those scans?
Yeah, this is an area where I think we have a lot to develop, because at the moment, even for the standard chest pain patients, the administration of GTN and beta blockers is being given by the clinical team. We don't have radiographers or nurses that are doing that for us, although we are looking to develop that service. At the moment, it's done by the doctors, and that's either the doctors in training or ourselves. And so as a result, we're probably split 50-50 between supervising and reporting. Our hope is that we will move to a position where the consultant staff will be involved less with the standard CT coronary angiograms and allow our junior trainees and our radiographers to do the acquisitions, because we've got well-established protocols that are working well for us on our current equipment. With regard specifically to the congenital heart disease, the reality is they tend to need a much more bespoke investigation, and it is very much dependent on what the clinical question is, what their anatomy is, whether it's pre or post operative. And for those cases, we would always have the consultant in the room looking to try and time the contrast as best to be able to answer the clinical question. And a lot of that also depends on what you've got available. How old it is a child, the cannula size of the cannula, what flow rate we can give. So yeah, I envisage probably with the congenital heart disease, you will always need a radiologist or an imaging cardiologist in the room to provide the protocols, because they tend to be quite bespoke because of the variation of the disease.
So I want to get more into the congenital imaging, but perhaps a little bit later in the podcast when we dive into the more technical components of image acquisition. I want to transition now to comparing the program in which you've built and grown your CT practice to others that are in the United States, as well as others in the United Kingdom. So what sort of unique challenges may have come up with your program, both in its initiation and in its growth, relative to others both within your country as well as internationally?
Sure. And I think, I'm not sure if they're unique challenges, but there certainly were a lot. The issue, I think, for us predominantly has been around equipment. Because we've always had a dedicated cardiothoracic radiology department, finding staff that are enthusiastic and keen to train in this has not been difficult, because all of us are engaged in the process. And so we've always had people that have wanted to do this, and supportive cardiology colleagues who are keen for us to take that on. The difficulty is in getting the appropriate equipment to do this well. And I think it simply comes down to cost. We are a university hospital, and there is some research done here, but we don't have dedicated research scanners here. So we're dependent on the NHS providing these machines. And in all honesty, it took the nice guidelines and the clarity of that decision to say this is the right investigation for these patients at this time, to be able to start unlocking the finances we needed to expand our service, to buy the latest equipment, to expand the number of scanners that we had, to give us the time and capacity that we needed. From a personnel point of view, in addition to the radiologists who've always been enthusiastic and keen to learn, and our trainees are always very enthusiastic as well, because I think it's quite an exciting area of radiology to learn, because you're in the scanner, you're working with the radiographers, you're not just sat in a room reporting separately. I think people like being engaged in the process. We've also found that actually getting radiographic staff or technology staff involved has been good, because actually it's one of those few areas where there's a constant interaction between the radiologists and the radiographers. And so we've always had very healthy relationships with them in our department, and finding radiographers who are keen to become specialists and learn about ECG gating. And we've now got one or two that are looking to move forward and start administering beta blockers as well. So finding personnel has not been a problem in our institution. It's getting the equipment has been the main challenge.
James, I just want to take up that point a bit further. We've seen some rapid upgrades in both hardware and software for CT scanners recently. And obviously with the advent of spectral CT and potentially even photon counting CT on the near horizon, it looks as though there's going to be exponential growth that will happen. How's procurement addressed within the UK healthcare system to keep up to date with all of this latest technological advancement?
I think is a challenge, Alastair. I do. The truth is, the way it works in our hospital, all of our imaging equipment is managed by a managed equipment service. So we don't own any of it. We lease all of it. If there is a change in clinical practice, we have to change that contract. And then we have to justify the reason for that expense. As it stands, with the situation we're in at the moment, we've recently had a big expansion in our cardiac CT off the back of NICE guidelines and acknowledging that we had increasing waiting lists. And I have to be frank, that is one of the biggest drivers of finding finances in our current healthcare system with the challenges we have. Waiting lists drive that sort of thing. And the numbers waiting for cardiac CT were too high. And off the back of that, the trust said, well, what are we going to do about that? We said, well, we need to have another CT scanner. We need to appoint more radiologists. We need to have more radiographers. And if we're going to do that and we're going to build this bespoke service, let's look at the equipment options that are available to us and really assess the pros and cons of spending more money on a better scanner. Will that increase our throughput? Will it give a better outcomes for our patients? And that wasn't a hard argument, because actually once we sat down and looked at how the latest equipment can offer us so much better quality imaging and give us a reliable diagnosis more frequently. When it comes to challenging cases, whether it's tachycardia because we're imaging children, or atrial fibrillation, or bariatric issues, we managed to get a new piece of equipment which was capable of these things because of the advantage it held, and that we'd be able to image more patients. But it comes down to producing a good business case and proving that, because these things are more expensive.
And do you think in the UK, the provision of cardiac CT is mainly limited by access to the scanners rather than by the reporters or the technologists to undertake these scanners?
I think it's a combination of the two. As I said, I don't think our experience here in Southampton is the same across the United Kingdom, because we've got dedicated cardiac images here. That's always been one of the strengths of our department. But clearly in other centres, particularly some of our smaller district general hospitals, they may not have dedicated cardiac imaging staff, whether they don't have imaging cardiologists or they don't have cardiac radiologists. And in actual fact, in those institutions, if you haven't got engaged key personnel, getting a service off the ground is a real challenge. The reality is, relationships between radiology and cardiology departments, historically, there hasn't been much of an interaction, because if you think about it, cardiologists will do their own angiography, they'll do their own ultrasound in the form of echo, and therefore don't necessarily use radiological services that much. This is a complete change for that model, and therefore, unless you have key radiologists and cardiologists who are keen to set up a service like that together, it stalls. And there are certainly examples of that in the United Kingdom where, because there haven't been images who are directly interested in cardiac CT, because it hasn't been part of their normal working platform, it's been slow to evolve.
James, quick question with regards to allocation of your scanners at your institution relative to non-cardiac imaging. Are the CTs that perform cardiac CTs also being used for non-cardiac applications?
Yes, they are. We have 6 or 7 CT scanners across our institution, of which one of them is now one of the latest scanners. So all of our cardiac CT is done on that list, but it's not used for that purpose exclusively. I would say the other area that we use it most for is our pediatrics, because as everyone will be aware who's listening, is actually the latest scanners also offer advantages as far as radiation dose and speed of scanning. And that for general pediatric imaging, not just cardiac pediatric imaging, there's an advantage. So we share our scanner with the pediatric service.
And James, we know that, with a lot of the ways that we can read scans now, there are these layered technologies that we can add on to them to either assess, computational fluid dynamics or potentially even doing, advanced plaque quantitative characterization. How feasible is it to incorporate these sort of solutions into clinical practice from what you found in Southampton?
That's a really good question, and I think it varies across the country. But if I talk to Southampton's experience first, we have been involved in research from other centres looking at CT-FFR. We've contributed to the platform trials, and we have also developed our own multi-centre research trials that have been led by Professor Nick Curzon out of Southampton, who led the forecast trial, again looking at the role of CT-FFR. So we have been able to get the model working in the research forum. We locally have struggled to be able to implement it as a clinical tool, and that has again come down to funding. There's a variation across the country depending on who's paying for these things as the availability of this. So we do not use CT-FFR as a clinical tool in this hospital at the moment because we haven't received funding to provide it. That is not the case elsewhere in the country where it is now being used routinely.
And our international audience will be very aware that the United Kingdom has a facility for auditing a lot of these new technologies through the guise of NICE. If something gets a green light from NICE, whether that be through a technological appraisal guidance on a diagnostic technique or as part of a pathway, does that green light translate into immediate change, or have you found that actually it's a bit more complicated than that?
It's certainly more complicated than that. I think it helps. I think without NICE approval of a technology, it's almost impossible to get things moving. If NICE have evaluated a technology and say, yes, it's appropriate in this space, but there are other modalities that are also appropriate. If those other modalities are already available within an institution and you've got your system set up around it, the impetus for change is less. So I think having NICE approval of a technology is important, but it doesn't guarantee that it will be taken up. And I think a lot of it depends on what other services and what other experiences that are available in that institution. It's a bit like not throwing the baby out with the bathwater. If you've got an amazing nuclear department and they do a very good job, would you want to replace it? We have a very large cardiac MRI service here in Southampton and been doing stress perfusion imaging for a long time. We also have a stress echo service. So if you were to say, lock, stock, right now we're going to move to another technology, it would involve quite significant change in other parts of the hospital. Now, I'm not saying that that's not what should happen, but obviously you can imagine the levers that promote change when you've already got established services up and running well, there's not quite such the demand.
So James, apart from some of the potential financial constraints with building a program, there's obviously training related constraints, both on the part of the imagers as well as on part of our radiographers, our nursing staff, etc. First, starting with your imagers, what sort of standard do you expect from your independent imaging reporters in terms of training?
So locally, we've always expected the equivalent of SCCT Level 2 cardiac CT accreditation. The BSCI also offer a similar accreditation program, which was mirrored on the SCCT program. So we would expect Level 2 as a minimum. All of the consultant radiologists here in Southampton now are Level 3 because they're experienced. So we would expect engagement in that process. Off the back of our experience here in Southampton, we've seen a similar adoption in the surrounding district general hospitals where we have some very, a large amount of cardiac CT being done in our district general hospitals near us. So as a patch in the United Kingdom, the central southern England we're well provided for. The advantage there has been that now that we've got several hospitals all involved in the same training scheme, that means that any trainee radiologists or cardiologists coming through this area will have access to learning how to do a lot of cardiac CT. And we are seeing more recently that a lot of trainees are wanting to then get consultant jobs in the area in which they trained for a myriad of reasons. But that means that even the new appointees as consultants have actually grown up in the system of doing a lot of cardiac imaging, and they've already got their level 2 or level 3 cardiac CT training accreditation. So it's evolved from a few enthusiastic individuals inspiring a lot of other people to join in. And therefore, we've actually got quite a high number of people who can do it within our area within the United Kingdom.
And James, have you seen that in terms of the cardiac CT community across the UK expand in that sort of way? Is this a local effect, or are you seeing this more on a national level as well?
I think it's happening in patches, if I'm being brutally honest. Those centres that started early, and I mentioned earlier on Derriford in Plymouth, down in Devon in the southwest of England, they started very early, and they've had a very similar experience where they've got a large number of highly trained individuals, which has had a great impact, not just for the Derriford Hospital, which is a teaching hospital like ourselves, but also those surrounding hospitals. And there are pockets around the United Kingdom where we've seen numbers expand. There are still areas in the United Kingdom where that is not the case, although it is beginning to change. In the introduction, you said that I'm involved with the BSCI and the BSCCT. One of our roles is to advocate for cardiac CT and encourage, help with training and encourage the responsible bodies to take this up. And one of the things I'm most proud of during my time with the society is we've now got cardiac CT required as both the College of Radiology and the College of Physicians curricula for cardiologists in training and radiologists in training. So we're beginning to move to a national expectation of the experience of a few core centres. So we're not there yet, but I think we will get there now that it's now in our formal curriculum. And we certainly within radiology, we are expecting a core radiology trainee to be able to supervise and report a cardiac CT once they finish their training. For cardiologists, it's not quite that level. It's saying that they must have experience, and only those that are subspecializing in cardiac imaging achieve that level. But that should ensure that we have large numbers of people capable of doing this in the future.
And where do you see this moving over the next 5 to 10 years, James? Is it about getting everyone fluent in being able to look at CTs and being able to make some sort of a first attempt at being able to look at those scans and being able to report them? Or is it about getting those super specialists who are, really good and have that really top end clinical knowledge to be able to do those deep reads?
I think it's the former. The reality is we have already accepted in the United Kingdom that CT is probably the most affordable first-line investigation for investigation of coronary artery disease, and all of the data that's coming out is supporting that. We're seeing that we are identifying more coronary disease, and we're having an impact on these patients, and particularly now with a pivot towards volume of plaque and plaque assessment, which CT does so very well. I think we've got the right test. Now, the numbers involved then, if we are going to continue investigating patients like that just for the stable chest pain patients, means that this will be one of the commonest investigations we do within the radiology department. You cannot have that as the preserve of a few select specialists. It needs to be a core skill for all imagers, a bit like CT pulmonary angiography has become. So the only way to do that is to make sure that all radiologists are trained to do it. Clearly, there is going to be a role for specialists when it becomes involving more advanced practice, or perhaps some subspecialty areas which are less common. But I think by and large, the investigation of coronary artery disease, one of the commonest killers in the Western world, we need to have a lot of people who are capable of doing this. The advantages are we've got equipment now that is actually providing so much better image quality. It is easier to get good quality imaging, and I think that is really helping. We need to make sure we've got well-trained radiographers that we get those good quality images, but we are getting there. And the other thing to mention is this is only going to expand. We've already seen several trials looking at the role of CT coronary angiography in more acute presenting chest pain. And I know in the United States, it's being recommended for its use for that. We haven't got to there in the United Kingdom, but we will. We will find areas where actually CT has a role in the inpatient setting as well, which will just expand the numbers further. And I think we will be doing thousands upon thousands of these scans, and therefore it needs to be a core skill amongst imagers, I feel.
James, super salient points about the role of cardiac CT, a more general approach to training our imagers to address chest pain related evaluations using cardiac CT. Want to transition to non-chest pain, and we kind of alluded to this a little earlier with regards to congenital imaging. The congenital program at your institution is very robust, and would like to know how it began or how it developed and how it's achieved this degree of strength.
Yeah, so I think that again was it was a natural evolution. We've been involved, the cardiac imagers, two or three of the cardiac imagers in our institution have been involved with the congenital side for a long time now, attending their MDTs. And historically, that started with, before my time, reviewing the reporting of the angiograms performed by the cardiologist, by one of our radiologists, to then when we started our cardiac MRI program, and clearly massive value for congenital heart disease patients with MR, no radiation, function and anatomy. And so we were doing a lot of MRs and follow-up of these patients. But as our experience grew with the stable chest pain CT coronary angiography, we started within the MDT setting when there was a clinical problem or there was a challenge to be able to say to the team, well, if actually you're interested only in reviewing, let's say, for example, the arch anatomy in a kind of coarctation case, and rather than taking to the lab for a diagnostic angiogram, why don't we do a gated CT and see what we get, and then we'll take it from there. And we found that we've refined our protocols, we've got better equipment, the radiation dose has come down, and now we're creating 3D models in some cases. And so we've seen both our surgeons and our pediatric cardiologists, both the invasive and non-invasive ones, really see the value of high quality 3D volume data sets for the evaluation of vascular structures and intracardiac structures. The biggest jump, there's no doubt, the biggest jump is with the latest scanner we've got, because the resolution and the temporal resolution particularly, and the spatial resolution is so much better. They have effectively stopped using diagnostic angiography for congenital heart disease, which was certainly being used until quite recently, but that has now stopped because we're doing CT for the predominant of it, most of it.
That's a really interesting transition, isn't it, James? Because obviously I'm seeing this in that wearing a cardiology hat, where we always like to have randomized control trials or even meta-analyses of randomized control trials. And we've seen those come out recently where you've got discharge comparing invasive angiography versus coronary CT. So there's still a plethora of trials coming out within that remit. And yet within congenital CT, obviously the ability to conduct those sort of studies is going to be a lot more challenging. But you can actually have that collegial discussion in-house to sort of drive that change. And that sounds as though it's just a very different model for building a program.
It absolutely is. I agree with you. I mean, the amount of data that's generated around adult, acquired cardiology is huge because we've got huge volumes of patients. Whereas in the congenital population, even if you take a condition that is quite common within our world, tetralogy of Fallot, the variation of disease is huge. And every consultation in the MDT, there are bespoke aspects of, what does the echo show relating to this and that and the other. And therefore, they tend to be very individual decisions. And it's very hard to find data that can support all of your decisions. And a lot of it comes down to clinical experience. And what we're finding is, as we've learned to use cardiac CT in this population, we're learning what it's good for and what it's not good for. There are risks in that. There's no doubt there's risks in that. One of our surgeons is very keen on the use of 3D models, because conceptually it's a tool that he can understand better than looking at our 2D images on a monitor. But as we all know, who's listening to this podcast, is actually that any model that's generated from a CT data set is just one representation of the raw data, and you can create stenoses, you can create larger VSDs than you want to if you're not careful. So you have to be very careful when you're evolving like this to not over rely on new techniques, because mistakes can be made. And so that's the value of the MDT, which is really robust in our institution. We're not just looking at one modality, we're looking at several modalities, and you've got several aspects coming at it, whether it's surgical, interventional, cardiological, or radiological. We do spend a lot of time on these patients.
And are there any directions of travel as to where CT is going to be incorporated into the surgical planning? Is it going to be live in the operating theatre for the surgeons to review in the near future?
Well, there are a few things. I don't think it's going to be live in the operating theatre at the moment, but I know that our interventional cardiologists are trialling virtual reality at the moment. And some of them have found that quite useful, actually, for their understanding of lesions. If you're an interventional cardiologist and you're trying to get across an atrial septum to access a baffle or something like that, having a 3D data set which you can manipulate within a virtual space, whether that's within the operating theatre or before you get to the cath lab, that's something that they're looking at the moment, and we haven't decided whether that's a technology we're going to take up. But I think yes, that we will see changes in that space quite soon.
Excellent. This conversation has been extremely informative, James. Thanks again. Do you have any final comments before we close?
Just to say, I never cease to be enthusiastic about cardiac imaging, whether it's CT or MR, because the evolution of the technology happens so fast, and our job is to learn how to use this technology and then really importantly learn how to appraise it, whether that's through large volume data sets or on a one-to-one level, to make sure we're using it for the best for our patients' best interests. But it's a hugely exciting field to be in, and I'm privileged to be involved.
Wonderful. Thank you again for joining us, James. We really, really appreciate it. I think this has been an awesome installment in our Building a Cardiac CT program series. To our listeners out there, we hope you enjoyed this as much as we have. If you like what you hear from us on the podcast, please rate, review, and subscribe. Once again, this is the Donut of Destiny. Cheers. Remember to check out the SCCT Starter Kit for a collection of useful resources to help guide healthcare facilities interested in starting a cardiovascular CT program for their patients. It is available for SCCT members free of cost, and it is available for non-SCCT members for a subscription fee of $300 per year.